going to talk about Achilles tendinopathy. So what we're going to cover tonight, so we'll go through a few stats. We'll look at the different types of Achilles tendinopathy. We're going to look at the causes, signs and diagnostic tests, how to evaluate patients' response to treatment. We'll look at tendon health, presentations of the different Achilles tendinopathies, risk factors for developing this condition, management, load management in athletes, phases of rehabilitation, prevention, tendon architecture, and we'll go through some cases. And we'll also talk about the use of shockwave therapy for this condition. And we'll look at some literature. Hopefully we'll get through all this stuff. Some of it I might breeze through rather quickly. So if I go too fast, just ask Danny to send me a question to slow down or comment. All right, so a little bit about me. So I'm a chiropractor with special interests in sports rehab. I have 2 university degrees, one from Canada and one from here at Macquarie University, master's in chiropractic. I've done some advanced training in soft tissue technique called ART. It's one of the most, I'm one of the most experienced practitioners in Australia with this technique. I've been doing it for about 18 years now. I'm a certified member of the specialist instructor for Swiss Dola Class Academy since 2016. I've presented shockwave seminars throughout Australia and Southeast Asia. And I've also worked with orthopedic surgeon Dr. Munjadel Madiris at his rehab clinic at Norwest Hospital in Bella Vista here in Sydney. You might have heard of him. He does the bionic legs for amputees and stuff. So he's been on TV and stuff a few times. That was interesting working for him. I'm also a published author. I co-authored a book on back pain back in 2014 with Dr. Rob Bonello. And I have 2 clinics, one in Sydney, one in the northern beaches of Sydney and one in Pymble. And my ethos is to treat the cause, not the symptom. And that's my website if you want to check it out. All right, cool. So we'll just go through some stats. Approximately 6% of the general population experience Achilles tendon pain at some point in their lifetime. A study out of Netherlands found 1.85 per 1,000 people had mid-portion Achilles tendinopathy in the general population. Elite long distance runners have a lifetime risk of about 52% developing some form of Achilles tendinopathy. 65% of Achilles tendinopathies diagnosed in the general practice are not sports related. So it's not just athletes that get this condition. 3 to 5% of Achilles injuries in runners can be career ending. So athletes have to retire due to the condition. So we have a few more here. Also, 43% of track and field athletes reported having either current or prior symptoms of Achilles tendinopathy, with the highest prevalence of about 83% in middle distance runners. Likelihood of full recovery to physical activity from chronic symptoms from Achilles tendinopathy is estimated about 80%. So it's a good recovery rate. About 80% will get full recovery from this condition. So that's pretty good. Annual incidence rates of Achilles tendon disorders about 7 to 9%. So here's a little quote I'd like to show. Take care of your body. It's the only place you have to live. So I kind of iterate that to my patients that, you got to take care of yourself, and, what you do when you're younger affects you when you're older. So do things that are going to be kind to your body in the long run, because we all want to be here for a long time. So breakdown of Achilles tendinopathies, about 20 to 25% are insertional. About 55-65% are mid-portion. Another 9 to 25% are proximal musculotendinous junction. Approximately 30% have bilateral pain. And some people have a bit of both. Like I have some patients that have insertional and some mid-portion Achilles tendinopathy concurrently. So it's not uncommon. So let's go through some intrinsic and extrinsic factors. So intrinsic factors, we got foot deformities, things like Hageland's deformity, impaired blood supply, gastrocnemius, soleus dysfunction, age. Obviously, the older you are, the more likely you are to get this. Sex, body weight. Obviously, if you weigh a bit more, it predisposes you to getting it. Metabolic disorders. If you have a metabolic disorder, you're more predisposed to getting tendinopathies in your Achilles. Lateral ankle instability. So if you've sprained your ankle a lot and have some instability in there, it can lead to the formation of this condition. Same thing with foot and joint hypermobility. So some extrinsic factors in athletes. Changes in training schedule, so increased training sessions or training hours per week. So we gotta keep an eye on that. It's good for athletes to keep a log of this and work with their trainer or coach to make sure that they're not overtraining. So we look at training errors. So again, that's where we look at excessive loads, or they don't have enough recovery time between hard training sessions, or if they're doing plyometrics and stuff like that. Past injuries, inadequate footwear. So some people need different types of shoes depending on the type of runner they are, whether they're a mid-foot striker or heel striker. Unsuitable training surfaces. So some people, like I see it all the time, people running on concrete, like pathways and stuff like that. It's just, it's unforgiving. It just, you don't absorb, the ground won't absorb any of the forces. So your body has to absorb all those forces. So that's going to cause some problems. Activities that place the ankle in dorsiflexion. So like if they're doing a lot of hill running, it's particularly worse if the patient has insertional Achilles. So some extrinsic factors for the general public. So past injuries, so if they've injured themselves in their lower limb, it can lead to problems or the development of Achilles tendinopathy. Again, inadequate footwear. So if their shoes aren't supportive, or they're too old, or they're not the right shoes for them, that's a problem. Unsuitable training surfaces. So again, you see them running here on a mountain or a hill. It can be very rugged and lead to problems. Increases in the work or daily activity can contribute to excessive loading. So again, that's for the general public. You're more looking at like their work. So if someone has to do a lot more like walking or climbing up and down stairs at work, then that can be a problem. So presentation for mid-portion Achilles tendinopathy. So it's part of the Achilles tendon with the smallest cross-sectional area. So it predisposes it to some problems. It's located 2 to 6 centimeters from the insertion of the Achilles onto the calcaneus. And the collagen fibers from the soleus, medial gastroc and lateral gastroc, they all come together into at the mid portion of the Achilles. So again, you have these different tissues coming together at that area. So it's kind of a transitional area. All right, so insertional Achilles tendinopathy, how it presents. So you get pain on palpation, usually within 2 centimeters of the insertion onto the calcaneus. They have self-reported pain, again, within that region. They get swelling of the tendon at the insertion, diffuse increase in tendon thickness, so they get the tendinosis, and they get limited ankle strength or function. There's also potential additional conditions, enlargement of retrocalcaneal bursa, intratendinous calcification, and bony defects such as Hageland's deformity, which occurs in about 25% of cases. So causes for insertional, we have anatomical abnormalities. Again, we're talking about these deformities such as the Haglunds, inappropriate footwear, and activities that place the ankle into excessive dorsiflexion, such as uphill running. So physiological changes that occur in the tendon. We have increased tendon cross-sectional area, so it kind of thickens. Reduced tendon stiffness, which is something that we don't want, because we want the tendon to be, it's like a spring, right? So we want it to be, the stiffer it is, the more it can absorb those forces and then recoil and give back that kinetic energy. They get altered viscoelastic properties in both symptomatic and asymptomatic tendons. And there's an absence of inflammatory cells. So that's where we changed the name from what we used to call tendinitis to the tendinopathy now, because often there's an absence of these inflammatory cells. There's also non-inflammatory intratendinous collagen degeneration that occurs, and collagen fiber disorientation and thinning. We also have hypercellularity with high concentrations of glycoaminoglycans and proteoglycans and neovascularization. So signs and diagnostic tests. So we have your standard pain on palpation, which has about a sensitivity of 84% and a specificity of 73%. We have subjective report of pain. So that's where the patient reports pain in their Achilles, which again has pretty high sensitivity, about 78, and specificity of 77%. We have the ARC test. So it's a test for the Achilles tendon, where the Achilles tendon is palpated to identify the thickened nodule. If the thickened nodule is present, you pinch it and you feel how much pain the client or the patient gives you a pain rating, and then you push it into end range dorsiflexion and you retest it. And if there's a reduction in pain with active dorsiflexion, it's a positive test. And then we have the Royal London Hospital test as well. And it has a specificity or sensitivity of 51% and a specificity of 93%. So for appropriate treatment, it's essential to have an accurate diagnosis. So the treatment between, again, if we have the mid portion and insertional is different. So we want to make sure we diagnose it appropriately. And sometimes we have other things. It might be a misdiagnosis. It might be actually like a bursitis, or it could be some kind of tenosynovitis, something else in the area. Evaluating patients' response to treatment. So full symptomatic recovery does not ensure full recovery to function. So the symptoms don't always match people's ability to perform. So they might be pain-free, but they still can't perform at a functional level. If symptom resolution is the only goal for recovery instead of recovery, all the domains of tendon health, there is potential to miss certain issues. So we want to make sure we're covering everything and not missing anything, so that people end up with re-injury, which is 27 to 44% for Achilles tendinopathy. Danny, how are we going? Any problems?
Perfect. Brilliant. Good pace.
Okay. All right, outcome measures that consider all domains of tendon health. This is from Karen Silbernagel. She's one of the top leading researchers for Achilles tendinopathy. So she talks about looking at symptoms. So you got your pain, stiffness, and passive range of motion. Function, so calf strength, jumping, running. We want to also look at the structure, the morphology, and mechanical properties. So we can look at that sometimes through imaging. And psychological factors. So some patients will develop kinesiophobia and pain catastrophizing. So we want to look at those factors and address those as well, so that so people aren't scared to actually load these tendons once they've had these injuries, because if they've had some pain in the area for a long time, or they get back a imaging that shows some tearing, it can be scary for them. They think it's vulnerable and can rupture at any time. So we have to work on the psychological factors as well. So this is her Venn diagram showing the tendon health and how they all interact together, all the symptoms, function, psychological factors, and structure. And if we get all those right, then we get a healthy tendon. Historical conventional treatment. So we used to always just tell people to rest, do some modification of their activity, take some anti-inflammatories, do some physical therapy of some sort, even sometimes do cortisone injections that'll sort you out. Also splints and orthoses. So that's what we used to do. Achilles tendinopathy can cause sufferers to decrease their physical activities. So there's potential negative effect on their overall health and well-being. So that's where we're talking about the psychological effects, because a lot of runners, if they can't run, we've all had patients that are those crazy runners that if they can't run, they're gonna like jump off a bridge or something. So for those people, if they can't run, it's very devastating on their psychological well-being. So we have to be aware of that and give them alternatives for things that they can do. So time off due to injury can also carry, so that's just what I was saying there before with the mental health related problems. So current non-invasive management approaches, this is what we tend to do now. We have exercise therapy, which is the gold standard. We have activity modification. We have shockwave therapy. We have laser therapy. We have soft tissue therapy, kinesiology taping. We have dry needling. We have therapeutic ultrasound and many electrotherapies. And this list is not exhaustive. It's just a few of the main ones that we do. So risk factors for developing Achilles tendinopathy. So we have biomechanical faults. So that's where we talk about hyperpronation of the foot, decreased ankle dorsiflexion, knee valgus, decreased plantar flexor strength, stuff like that. Anatomical variations. So we have like pes cavus or tibia vara, leading to the development of the condition. Systematic diseases like diabetes affects the blood flow, obviously, which can lead to the development. Asymptomatic changes in the tendon structure. So we get tendinosis, smoking, age, inappropriate running shoes, activity level, obesity, family history of tendinopathy, use of antibiotics, and seronegative arthropathies like AS. So often the etiology is multifactorial, and it's rarely only due to one risk factor. In the past 3 decades, the incidence of Achilles tendinopathy has increased, owing to greater participation in recreational and competitive sports. So it's not just that it's more common. It's kind of more common because people are a little bit more active in sport and stuff. So this is from Silbernagel as well. She talks about load management in athletes. So load management needs to be discussed with all the stakeholders because many considerations can come into play. So the stakeholders are the athletes, the coaches, the trainers, and managers, and also medical staff. So this is this is professional or semi-professional athletes. We want all these people to be on the same page when dealing with this condition, and the outcomes are much, much better when everybody knows what they're supposed to be doing and how to treat this condition. So symptom management and load reduction phase. So that's the first phase. The purpose of this phase is to stop the negative cycle of overloading and continued injury progression. So it's basically to kind of bring it back to basics. Let's start and make it real simple so we can't get this wrong. It's better to use patients' level symptoms of pain as a guide when determining the appropriate level of activity. So all those other stakeholders other than the athlete need to kind of listen to the athlete to guide them with this in terms of their pain. Here, rises, Silbernagel calls them rises. A lot of people say raises. I use it synonymously. You want to go from a neutral or flat surface for starting. You don't want to go off a step or on an incline when you're just starting out. So start with the bilateral heel raise or rise. If the patient is unable to perform these, then try some isometrics or use some form of aid like support rails or a chair, or they can have like a resistance band that helps take some of the weight. The patient's degree of symptoms and irritability guides the progression through the phases of rehabilitation. So again, we have to rely on the athlete or the patient to give us that symptom feedback before we can progress with this stuff. All right, so also complete rest has been shown to be unhelpful and even prolong recovery. And the pain monitoring model has been used successfully as a guide for tendon loading in patients with Achilles tendinopathy. So other things you can do if patients can't tolerate much load is you can give them things like deep water running or biking, so they put a lot less load on the tendon. It's a good way to start them off if they're in a bad way. So new approaches. This is that pain monitoring model. States that exercise activity that does not cause pain above a 5 out of 10 on the VAS is safe. So it has huge benefits for patients as it allows them to continue their exercise activities, which may have positive effects on their general health, mental health, and quality of life. Athletes with Achilles tendinopathy would potentially benefit from being able to continue their sport. So again, for a lot of athletes, that's the goal. Is we want to keep them in the sport to some degree. Okay, even if it's just a small bit that they can do at practices and stuff. So this is that pain monitoring model from Silbernagel. So we have the pain scale here, which you can see. Up here, the safe zone, which is no pain, 0, and up to 2 is safe zone. So we want to be in this acceptable zone here, where it's about 2 to a 5 on their pain scale. All right, we don't want to exceed a 5. That's where we're getting into where it's going to cause some inflammation or further exacerbation of their condition, where it just takes a long time for it to settle down. So this 2 to 5 zone is kind of the sweet spot we're talking about for this pain monitoring model. So the recovery phase lasts usually between 2 to 5 weeks, and it can be longer if needed. The goal of recovery is to strengthen the lower leg and increase the Achilles tolerance to load. Exercises are performed daily. As the patient's symptoms improve, the exercises are progressed by increasing the number of reps, the range of motion, or the speed of the movement. For those with mid-portion tendinopathy, heel rises are progressed to an incline, which I was talking about before. We want to avoid at the start, but once they've gone into this recovery phase, we can start pushing them a little bit to do inclined or step off stuff. And it's based on how well they're going. You don't always have to follow week to week kind of thing. If someone's doing really well and they tolerate the incline or step off, get them doing it, as long as they're not exceeding a 5 on that pain monitoring scale. So then we go into the rebuild phase. So the rebuild phase is lasts 3 to 12 weeks, depending on the individual. The goal of this phase is to transition to heavier strength training of the calf muscles, increase or start running and jumping activities, and further promote their tendon recovery. Add additional loads to all the heel rises, exercises, backpack or weighted vest or kettlebell, dumbbell, doesn't matter. They're all just loads. So whatever the patient's got or whatever you have at your office that you can use, just use it. Obviously, backpack or weighted vest kind of distribute the load a little bit better. I usually start with about 4 to 5 kg until the patient can easily perform about 3 times 15 heel raises. And then you want to add about 1 kilogram per week. Then you can progress to some plyometrics, start with bilateral jumps and progress to unilateral jumps. And then the rule of thumb is before an athlete is allowed to return to running or jumping, pain during daily walking should be a minimal. So 1 to 2 out of 10 on the pain scale. So again, you can use other tests to basically figure out where they're at. You know, if they can't walk without, if they're walking with, you know, a 4 or 5 out of pain, you can't get them back running. They're just not ready for it yet. So you're just going to mess them up if you do that. So return to sport. So the goal of this phase is to return the athlete back to full competition while the Achilles and lower limb functions continue to improve through rehab, the rehab program. Since athletes may be asymptomatic at the later stages of rehab, they often make mistake of returning to sport prematurely, which can result in a flare-up of the condition. So again, that's where we want to do these functional tests with people to see where they're at, because sometimes when the pain's gone, they just think they're ready to go. So that's where we want to do some of these strength tests and stuff like that to figure out where they're at. So in order to avoid the evaluation of symptoms, stiffness, pain, and swelling after training, especially the following day, is crucial before determining the appropriate increase in training load. So that's where we're gonna, after the training session, we're gonna look at all those things: stiffness, pain, swelling, to see how they're coping with what we're giving them. And if they're not coping well, then we back it off a little bit. If they're coping well with it, then we can look at maybe increasing it a bit. And again, the pain monitoring model is a useful guide at this point. So again, even when asymptomatic, the functional impairment and strength deficits can persist. So that's where we got to keep coming back to that and make sure the athlete is aware that even though they're pain-free, that there can still be problems. And this is how you can show them. You can do some of these tests and go, look, you can see you're still weak. When we do, you know, the single leg raise, you can only get to 25 when you should be able to get to 30 or 40, you know, so your test kind of speaks volumes. All right, figuring out progression and return to sport phase. So the intensity, duration, frequency of Achilles tendon loading are considered when progressive increasing the demand on return to sport phase. Sport activities can be classified into light, medium, or heavy or high based on the athlete's rating of pain after the activity and perceived Achilles tendon exertion using the Borg scale. So I got a picture of the Borg scale after here. Activity level should be decided by the athlete, coach, and clinician. So again, we want those stakeholders to work together to try and figure this out. So it shouldn't be just one person's decision. Tendon tissue requires a longer recovery from heavy loading. So you need, according to Silbernagel, we need 36 to 72 hours after heavy loading, whereas lighter activities can be performed more often. So light level activities can be performed daily, and medium level activities need to be followed by a 2-day recovery. And then, as we said, the high level activities need to be about 3 days recovery. So this is her model, and this is based on quite a few studies she's conducted. Activities are generally reclassified every 3 to 4 weeks. So that's where you're going to revise the training program every 3 to 4 weeks and keep adding or changing the program based on the athlete. It is recommended that the athlete document pain and symptoms daily, so they should have like a pain journal that they write in and grade the perceived exertion on the Achilles tendon after each activity. So that's really important to do with athletes, to keep on top of this and not just go, oh, I think I was good yesterday. Just actually get them to write it down, or there's apps and stuff nowadays where they can just type it in. They can even if it's just a pain rating, even if they just put the pain rating after training or during training, that's kind of the bare minimum. So this is that Borg scale. So this is how you figure out what whether it's heavy or mid or light activity. So based on this this rate of perceived exertion here. So you can get that off the net. It's a common one that's used. So prevention, for prevention of Achilles tendinopathy, to prevent it, we must address perpetual overloading at an early stage. Problem with early detection is that first symptom is often pain, so that limits sports participation. So they don't often detect it till it's well and truly established. This is usually preceded by weeks or months of minor pain, morning stiffness, which often go ignored by the athlete and clinician as long as the athlete can continue to compete. So that's what we're talking about. Even these little things, we want athletes to tell their coach or their clinician about, so that we have an idea that this could be a problem, and then nip it in the bud. So to combat this, clinicians and athletes need to monitor training loads, sport participation in recovery sessions in order to detect sudden changes in training loads that increase the risk of Achilles tendinopathy. The earlier the injury is detected, the shorter the expected time to full recovery. That's pretty obvious. All right, so here's some basic tendon architecture. I'm sure most of you are aware of this, but the collagen accounts for about 65 to 80% of the dry mass. With type 1 collagen accounting for about 95% of that. The rest of the collagen is type 3, 4, 5, 6, 8, and 14, and 15. So there's also proteoglycans, which account for about 0.5% of dry mass, including decorin, bursican, and lumican. And we have glycoproteins, about 5% of dry mass. Insertional Achilles also contain collagen type 2 and 9 and 11. Oops. And we also have tenocytes and tenoblasts account for about 90 to 95% of the tendon cells. And the other 5 to 10% of cells in tendons are composed of chondrocytes, synovial cells, and tendon sheaths, capillary endothelial cells, and smooth muscle cells. So again, we have all this breakdown. It's like a Russian doll. All through here, it gets bigger and bigger until we get the full tendon up here. So we got the phases, basic phases of healing. From this condition, we have inflammation, repair, and then remodeling. So I'm sure most of you have seen this before. Just a good visual reminder of what occurs. So we have the inflammation phase here, where there's some damage to the tendon, and then we have neutrophils, monocytes, erythrocytes, and platelets all increase to help repair the damage. And then we get into the reparation, where there's proliferation, and there's collagen type 3 activation of local tendon stem and progenitor cells. And then here it's the remodeling consolidation phase, where it's starting to knit together a little bit better. We get the fibroblasts, collagen type 3, and cellularity and matrix production goes down. And then finally the maturation phase of remodeling, where we get that the good stuff, the collagen type 1, which is what we're all after, because it works much better to get the tendon back to where it should be. It's prognosis. Full recovery can take a year or longer. Re-injury is common, especially when return to sport is rushed. Very important to constantly reassure patients that they are improving even when their symptoms remain unchanged. So I always tell people, trust the process. You'll get the result in the end. Imaging results do not always correlate with symptomatic pain or functional capabilities. We've seen studies where asymptomatic people have positive structural changes in their tendons, and they have no functional or symptomatic changes at all. Have patients fill out objective questionnaires that can be filled out regularly to map and show their progress. So it's not only good for clinicians to check our work, but it's also good for the patient so that they can see objectively that there's an improvement in their condition. Because some people, they just focus so much on the pain that they forget how bad they were when they first presented. I'm sure most of us have experienced that. So it's just kind of it validates that, you know, they are getting better and that you can prove that to them. And measure patients' improvements with monthly functional or strength testing. So that's where we can do those tests again, where they can see that if they're progressing or getting stronger, we can show them that we're heading in the right direction. So good news, the earlier the injury is detected, the shorter the expected time for full recovery. The initial symptom or soreness and stiffness are recognized and addressed early. If the initial symptom or soreness and stiffness are recognized and addressed early instead of being ignored, injury severity can be reduced with a smaller effect on the sport's performance and shorter time for full recovery. Tendinopathy is not a lifelong condition. Patients who continue to perform their rehab exercises even after the cessation of pain or functional impairment suffer far fewer recurrences. All right, so we're gonna go through some bits about shockwave now. I'm sure a lot of you have been waiting to get to this bit. So if you haven't seen this before, this is our Swiss Dollar class shockwave device. It was just released this year, I think, Danny, was it?
Last year, Adam. Yep.
Last year. Okay, last year. So shockwave therapy is treatment using powerful acoustic pulses which carry high energy to painful soft tissues of the body related to acute or chronic musculoskeletal conditions. The energy promotes repair and regenerative processes in bone, tendon, muscles, and other soft tissues. Shockwave therapy has been safely and effectively used for over 30 years. It is indicated in the treatment of approximately 90% of all musculoskeletal conditions. So the definition of shockwave, a shockwave is a single acoustic pressure pulse. It's characterized by a rapid high peak pressure followed by a rapid drop in the ambient pressure. So I'll show you this in the next slide. So where is it? There we go. So you can see here, this is the positive peak pressure here, which we call the compression phase, and then you have a negative ambient pressure here, which we call the tensile phase, and that's what creates these cavitation bubbles that we show here. So we have inside the handle, we have a projectile that gets pushed through with compressed air. It hits the applicator moves, creating kinetic energy, and it can penetrate with the handle we have here. It's a 15 millimeter head. It penetrates up to 40 millimeters through soft tissue. So again, the tensile phase is what creates the cavitation bubbles. And it's these cavitation bubbles, which is the theoretical model of how we cause physiological effects on tissues. So the physiological effects of shockwave therapy, these have been reported in multiple studies. So we get tissue repair, We have tissue regeneration. We have blockade of neurogenic inflammation. We have a decrease in cartilage degradation. We have decrease in the amount of substance P, which affects in the local tissue, which affects pain quite substantially, which gives you a local analgesic effect. We have mechanical muscle relaxation. We have improved movement of tendon gliding due to increased amounts of lubricin. We have stimulation of tendon remodeling. We have stimulation of proliferation and differentiation of osteoblasts. We have stimulation of proliferation of tenocytes. We have collagen synthesis, neovascularization, release of angiogenic growth and proliferating factors, increased local blood supply, resorption of calcium deposits. We get free radical formation and change in cell membrane permeability. So here's a little video we have of the focus device, and you'll see it comes into more of a focus or opposite of the radial, which goes outward. It comes into a focused area, and you'll see that here in the video, approximately here, and you'll see the formation of these cavitation bubbles. So this is that compression phase. You can see these compression waves. And then you have the tensile phase resulting in the cavitation bubbles here. I'll just play that one more time. So this is what it's doing inside the tissue. So here's a video. I don't think you can hear the audio on it, but I'll just describe a little bit what I'm doing here on this patient. So I'm treating his Achilles tendon. He's actually one of the cases I describe later on today. So we'll go through that case. But I'm just treating his Achilles here with the shockwave device. So I have the 15 millimeter applicator here. It fits really nice, just anterior to the Achilles. I'm just talking about using some contact gel in there. You need some gel with the shockwave device, because otherwise you lose all the energy. It's kind of like ultrasound similarly. So the handle fits in really nice with this kind of channel just behind the Achilles tendon here. So you can get into that anterior part, which is usually where most of the tendon degeneration occurs for most tendinopathies. So I'm just saying he's got a mid-portion tendinopathy, so his is a little more tender, about 5 centimeters from the insertion, and it's thickened. So now I'm just describing how I'm pushing his foot into dorsiflexion so I want some tension on the ankle while I'm working it, because I can actually feel as the shockwaves working the tissue, you'll get an increase in range of motion in their dorsiflexion. So I keep kind of working it until I get a change, a physiological change that I can feel. And usually patients can feel that too when it happens. But I just find it works a little bit better if I can keep a little bit of tension on that to try and feel that the tension through the Achilles. So he sped it up a bit here. I don't usually move that quick. So now I'm just describing that I feel a little increased range of motion by 1 or 2 degrees in his ankle after that little bit of treatment. All right, so let's talk a little bit about evidence for the safety and effectiveness of shockwave therapy. So this study done by Liao in 2018 it was a meta-analysis. So it had 19 RCTs, which included 1,189 patients. And the outcome, the conclusion was there was no adverse events, side effects, or complications reported in any of those studies. So that's about as good as you can get, which is 0. It can't get any better than that. So that's 1,200 patients. That's pretty impressive. So F and R here, that stands for F is for focus and R is for radial, with long-term intervention periods are superior to those with shorter intervention periods, regardless of the energy levels. That was the other conclusion they had. So the pros and cons for shockwave therapy. So the pros are it gives the patient some immediate relief. So you get that analgesic effect with the treatment. And one treatment can provide pain and healing effects up to 3 months later. So that's so even if they come in for one, I always tell people it's kind of like putting Miracle-Gro on your garden. It has effects not just that day or the next day. It continues to have effects weeks, and in this case, up to 3 months later with just one treatment. Again, there's no adverse events post-treatment. It's relatively inexpensive in terms of treatments compared to other forms of treatment. And shockwave therapy can be combined with other therapies. It often yields better outcomes when you combine it with other therapies, which we'll go through in some of the studies that we're going to cover down here. So a few cons: it's mildly to moderately painful, but you go based on the patient's pain tolerance. There's possible transient post-therapy skin reddening, but no bruising. So some people are a bit red in the area after the treatment. You also need to use contact gel, so it can be a bit messy sometimes if you get it all over the place. You also need to find a practitioner that has a device to get treated. So effectiveness of shockwave therapy in treating Achilles tendinopathy specifically. So Romp did a study in 2007, which compared eccentric loading to a radial shockwave therapy group and a control group. 4 months after the completion of the radial shock therapy, which was 2,000 pulses, about 8 hertz, 2.5 to 3 bar pressure for 3 sessions, they had a 52% of patients suffering from non-insertional Achilles tendinopathy, and 64% of patients with chronic insertional Achilles tendinopathy reported complete recovery or marked improvement. So that's pretty good, 52% and 64%. There was a 60% success rate in patients with the eccentric loading group. Again, we already know that the exercise therapy is the gold standard. So we're getting pretty close here with the shockwave as well. So Rump did another study in 2009. Another RCT looked at combining eccentric loading and radial shock therapy together. Again, he did 2,000 pulses, 8 hertz, 3 bar for 3 sessions, and increased the portion of completely recovered or much improved to about 82%. So again, that's where we talk about, we're not afraid for clinicians to use the shockwave device in combination with other. It's not this or that. You can have both if you want. If you want chocolate and vanilla ice cream, why not have them both at the same time? Okay. So that's what we want people to do, and that's what gives the best results. So we want to share that with people so that you can get, if you like your exercise therapy, then that's great, but you can get even better results if you combine it with shockwave. So here's a case. Bill's a 39-year-old runner who works at a high school as a teacher. He's had about a 15-year history of intermittent Achilles tendon issues. He likes to run 5K twice a week, and he does a faster run about 2 kilometers once a week. He used to actually do athletics as well. He did some sprinting last year when I first started seeing him. His height's he's about 6 foot and 80 kilograms. He has no other comorbidities. So presentation, he had bilateral Achilles pain at the bony calcaneal insertion point of pain, about 5 to 6 out of 10 upon waking. And when running, he had mild pain, 2 out of 10 further up the Achilles, about 5 centimeters above. So the mid portion was about 2 out of 10. So this is where we talked about some patients will present with both insertional and mid portion. So he was unable to run sometimes due to the Achilles pain. He had a positive bilateral Achilles pinch test. He was about 7 out of 10. He had a positive bilateral Royal London Hospital test. He was able to perform 22 right single heel raises and about 24 left single heel raises. So we know the kind of standards about 25. Treatment protocol, we use shockwave therapy, 2 to 3 bars, 14 hertz. So those other studies, those earlier studies that I mentioned with ROMP, usually the reason they use a lower frequency is because they're using older devices. Now our newer devices go up to 25 hertz. So we find about 12 to 16 hertz is usually kind of the sweet spot for most tendinopathies. So again, we use about 2,000 pulses on the medial and lateral side. So I would go 2,000 on the medial and then 2,000 on the lateral. So we got about 4,000 pulses on each Achilles. I combined that with some myofascial release of the plantar fascia, the flexor digitorum brevis, the Achilles, soleus, and gastrocs. We did some exercise therapy, which included 3 times 15 eccentric heel raises, which we progressed with increasing external loading. So he used a backpack, started with 5 kilograms and increased 1 kilogram per week. And he just went on level ground. He didn't use a step. And he also did some isometric holds. He would do 3 45-second holds daily. He also used, he went and saw his GP and got some nitroglycerin patches. He used about a quarter of a patch every day for about 3 months. So the outcome. So after about 6 sessions of weekly shockwave therapy combined with exercise therapy, myofascial release, and obviously the patches, patient was able to run with only mild discomfort, about 2 out of 10 VAS pain, and the same amount of pain post-workout for approximately 12 hours. The patient's kept up with his rehab exercises daily. So he's a phys ed teacher, so he's pretty good at keeping up with the exercises. I find most patients, especially once they come good, they rarely keep up with their exercises, and very few do them daily. If they keep up with them, they might do them 2-3 times a week, but most don't do them daily once they're good. But he has been, which is great. He still gets some bilateral Achilles pain, but he comes into the clinic for a treatment every 1 or 2 months just to get some maintenance treatment on it. And basically, I do what I was doing before with the shockwave and some myofascial release. We also do some joint manipulation on his ankle and feet joints. Of note, he developed a rash from the nitroglycerin patches, so he stopped using them. He wasn't sure if they did a whole lot anyways, but he got a rash from them, so that's kind of interesting. All right, we got another patient, Paul. He's 39-year-old personal trainer. He's also a carer for his disabled wife. He was training to compete in an Australian Ninja Warrior last year. He went to a gym, a Ninja Warrior gym, where they had one of these warp walls. I don't know if you've seen them, where they have to run up a steep angle. I'm sure if you've seen Ninja Warrior, you've seen that. And he was just doing that. He kept trying and trying. He wasn't super fast, so he didn't make it up too many times, but he would try like 20, 30 times, and he'd go there twice a week. He's about 178 in height and weighs about 85 kilograms. He had a chronic left posterolateral disc bulge as well, which he suffered a few years ago. He was also hit by a car while riding a bike in 2016, fractured his T10 and T11, which he required a Harrington rods, and they removed a year later. So he presented with left Achilles pain, which was about 4 to 6 centimeters proximal to the insertion onto the calcaneus, and he was about a 4 to 5 out of 10 VAS when walking. Pain was much worse with running, jumping, or walking uphill. He had a positive left Achilles pinch test, which was about a 6 out of 10. Again, in about 5 centimeters proximal to the Achilles insertion in that mid portion region. Had a positive Royal London hospital test. He was pretty strong though as a personal trainer, so he could do about 30 consecutive left single heel raises. So treatment protocol, we use shockwave therapy, 2 to 2.5 bar. Again, you work that based on the patient's tolerance. So he had a slightly lower tolerance than the previous case. So I worked with him on that. And again, you want to tell them that you want to increase the bar pressure because it leads to greater formation of those cavitation bubbles. So you kind of tell them it's not just because I'm a sadist, it's actually because you get a greater therapeutic effect when we ramp up the bar pressure. We use 14 hertz and about 2,000 pulses on the medial and lateral Achilles insertion. Sorry, that should be the mid portion. We did myofascial release of the plantar fascia, flexor digitorum brevis, Achilles, medial and lateral aspect, the soleus and gastrocs. Exercise therapy, again, we use the Alfredson model of 3 times 15 eccentric heel raises, and we progressively increase the load of 5 kilogram backpack with 1 kilogram per week. But he used a step. We were able to get him onto a step, which I tend to do more for the mid portion and avoid in the insertional. So the outcome, after about 4 treatments, weekly treatments of shockwave with combined exercise therapy, myofascial release, K-taping, and also joint manipulation. He was able to perform all his daily activities with no pain and only felt some mild pain when jumping or running. He's kept up his rehab exercises. He does them about 3 times a week. He still gets the odd recurrence of Achilles pain, but comes in for treatment to kind of nip that in the bud, and then we get it to settle down, and he carries on with his life. Cool. How are we going for time, Danny?
You're right on 9. So
okay. Okay. I think that's enough. With this. This is yeah. So I'll just go over a recap here, and then we'll go into some questions. Yeah. So Achilles tendinopathy is a common problem in the general population, about 1.85 per 1,000 people, or so, and more so in runners. You got 7 to 9% as the incidence of top level runners. Standard triad of symptoms are tendon pain, swelling, and impaired performance. Diagnosis is key. Patients can be easily misdiagnosed, and therefore the treatment provided will be less successful. So again, we got to get that diagnosis right, and diagnostic imaging like ultrasound can significantly enhance your chances of arriving at that proper diagnosis, and therefore the treatment outcome. Exercise rehabilitation has been shown to be the best single intervention. However, when combined with other treatments and modalities such as shockwave, the treatment effects can be even greater. Achilles tendinopathy is not a long-term, Achilles tendinopathy is a long-term problem. It can last 6 to 12 months on average and is prone to recurrence. So you got to make that patients aware of that from the get-go, so that they don't come in after like 3-4 weeks of treatment going, why is it not any better? Okay, I always try and make sure they understand it's a marathon and it takes time get them right. Okay. Measure. You need to track patients' progress in order to measure the effects of their treatment and rehabilitation program and adapt them accordingly. So we want to keep them coming in and measuring them so that we can keep changing things to get more progressions out of them. If we keep them doing the same stuff, we won't progress them as quickly and they won't get the same result. We still don't know everything there is to know about tendons and their physiology. So, we got to keep up with the evidence and keep doing things like we're doing tonight. I'm glad you all tuned in so you could learn a little bit, and we're all learning all the time. So keep it up. Stay current, read the most recent research, listen to podcasts, watch webinars, and attend seminars. You don't know what you don't know. So that's it. Shockwave's safe, effective, and well tolerated for the Achilles tendon.
Thanks so much, Adam. And